Truly, truly honored Dr. Mohan and Dr. Sanya. The honor is threefold today. One, as many awards you may have gotten, but the most significant is the award which your country gives you and your countrymen give you. Secondly, being with Dr. Sanyal, whom I have admired all my life, people coming from All India Institute, they always think about Arun Sanyal. So totally an honor. And thirdly, I was pleasantly surprised that on the list of the speakers for this August meeting, there were two of my class fellows here, Dr. Anant Nigam and Dr. Anil Bhansali. And Anil Bhansali was even my high school mate as well. So it is indeed a pleasure to be here today. So I have no disclosures. My chest is empty. So bringing down the LDL to a sweet spot. And I'll try to convince you what exactly the ideal level of the LDL should be. So as we all know, that the Framingham Heart Study started back in end of 1940s, early 1950s, and they introduced the term risk factors. Risk factors were those factors which were causative for the cardiovascular disease. The disease was rampant at that time in United States, the stage that we are in today in India and other low and middle income countries. They proposed 4 major risk factors, which were so-called modifiable risk factors, which we now call SMRFs, or the standard modifiable risk factors, and some unmodifiable risk factors also. And then those are the ones which have stood the test of time. These are the factors. When you resolve the factors, the disease should regress or resolve. When the Inter-Heart study was done by Professor Salim Yusuf, which is one of the finest studies of our times, 52 countries, 27,000 subjects. He extended it to 9 risk factors, or 6 risk factors and 3 the protective factors, and demonstrated that the lipids, they stood the test of time. And as a matter of fact, if you look at the population attributable risk, 50% of the risk could be attributed to the hyperlipidemia, as you can see in the first column. If you add smoking to it, approximately 2/3 of the disease, and if you add hypertension and diabetes on top of it, more than 3/4 of the disease is explained. Look at all the 9 risk factors, and more than 90% of the disease is explained by these risk factors. Continues with the PURE study, which is one of the largest of its kind, again by Dr. Salim Yusuf, and as you will see that there are approximately 200,000 subjects which have been enrolled into it from all 6 continents, as we all know. And you will see that the high non-HDL cholesterol remains on list anywhere you go, whether it is the high income countries, middle income countries, or low income countries. Not only that, the Inter-Heart study clearly demonstrated that there was 1-to-1 correlation of the hyperlipidemia and the odds ratio of having the major adverse cardiac events. As you can see here, they have used the ApoB to ApoA1, and here are the deciles of it, and you will see that there is a directly proportional relationship. Whichever country you are in or whichever continent you are in, the risk remains the same. Now, the onus is on us to find out who will live without the events and who will die of the preventable events, and when. So, we really need to find the Waldos, and then we need to deal with them. How exactly we deal with them, whether it would be at the precision level, it will be at the personalized level, or it would be at the population level. But the fact is that the risk comes from the way the histomorphology of the atherosclerotic plaques look like. The plaques that result in an event are the plaques which are very rich in the lipid core. As you can see here, this is the necrotic core, which are covered by a very thin fibrous cap, and at the thinnest site it has given way, and this necrotic core, which is full of thrombin and other thrombogenic factors, it is exposed to the blood, and you will see that the thrombus is formed, which leads to sudden death or acute myocardial infarction in these cases. Compare it to the stable plaque. The stable plaque does not have such lipid cores. It may have the lipid core, but it has a very thick fibrous cap, as you can see here. This cap is not going anywhere, and you will see that these lesions are rich in collagen and the calcification, as you can see here. So these lesions are stable lesions. Let's look at them as the histology. You can clearly see a large necrotic core full of the necrotic core debris, and you will also see some intraplaque hemorrhage in these cases. It is covered by a fibrous cap, which is very thin, normally less than 55 microns when the plaque has ruptured. And this cap is normally significantly inflamed by the cells of the monocyte macrophage origin. And these inflammatory cells, as you know very well, that the inflammation is now becoming one of the most important things in the high-risk plaques or the vulnerable plaques. Here it has ruptured, given rise to the formation of a thrombus. But you will see that this necrotic core is huge, and there is a significant amount of the atherosclerosis that you can see here. We have been given to understand that these plaques are small plaques. These plaques are not small plaques. They are huge plaques. They are large necrotic cores. I'll show you two other plaques here. One on the right upper side, you will again see that there is a large necrotic core, thin fibrous cap. In this case, again, there is a huge necrotic core, very thin fibrous cap, and they have all given way, and you will see the formation of a thrombus, and that leads to the acute coronary event. Now, you'll see that these three plaques, they all have something very common in them, that they all have large necrotic cores and thin fibrous caps. The only difference in these three plaques is that here the lumen is not affected, in this the lumen is modestly affected, and in this the lumen is critically affected. Why is it that even huge necrotic cores do not lead to significant luminal obstruction in certain cases? And here this is explained by something what you call as a Glegov phenomenon, or the positive remodeling, that when the fat starts to deposit, first there is an expansion outwards, and then after the 60%, 40 to 60% of the total vessel area, when is occupied by the plaque area, only then the plaque starts to impinge onto the lumen. And this is something which I always show by comparing Claudia Schiffer here with George Orson-Welles, that you will see that whenever there is a fatty deposit, there is a positive expansion, even though the deposition may be just 33% in either case. Now let's presume that we have a plaque which is very similar plaque, but the fibrous cap is still intact. Can we really call it a high-risk plaque or a plaque which is vulnerable to rupture? And let me present it in the similar three types here, that you will see the large necrotic core full of cholesterol crystals here. There is a very thin inflammatory fibrous cap, and you will again see it on the right upper side. Lumen is not affected, lumen is moderately affected, and lumen is critically affected. So they are all at risk of rupture and leading to the events. Now the question is that this is all after the fact. This is all after the death of these patients, as you can see in the histology. Can we really identify them by in the clinical situation? And this is something that we started working back in 2003 and 2004. First 64 slicer had come to us when I was in University of California, Irvine, and we did about 3,000 cases with those. And as you see, that we started to call it as a virtual not histology, but a hictology, looking at the CT angiography in these cases, and demonstrated that by looking at the Hounsfield unit densities, we should be able to identify the necrotic cores, which could be different than the fibrous plaques as well as from the calcification. And there was a clear distinction that we were able to make, and the necrotic core was when the Hounsfield unit densities was less than 30 Hounsfield units. Now, as you will see here, in this particular case, we have the patient with the unstable angina. The patient presented 24 hours after chest pain, so he could be taken to the CT lab first. We did the CT angiogram. You can see that there is a 50% luminal occlusion here, and then there is a huge positive remodeling, as you can see by the yellow arrows, and then red arrows will show you the huge necrotic core, which is the low attenuation plaque, or the Hounsfield unit densities, which were in negative side here. So we started calling these plaques as two-feature positive plaques, that is the positive remodeling and the presence of low attenuation plaque. And the reason that we gave it a very non-specific name was that we could not get our paper accepted because they did not want to allow us to call it a soft plaque or vulnerable plaque, because this was an observational study, and we did not have the actual demonstration of a plaque resulting in an event. So we were happy to call it a two-feature positive plaque, and the plaques which have none of these features, we call them as two-feature negative plaque. Looks like Claudia Schiffer here and looks like George Orson Welles in this particular case. So although we call them as the non-specific name, they have now become a lingo, and essentially the plaques which are vulnerable plaques, they are called two-feature positive plaques, and the plaques which are stable plaques are called two-feature negative plaques. So this is what we had demonstrated with the histology comparisons and all as well. Now we launched upon the prospective studies, and as you can see here that we were able to do these scans, and then we followed the patient up for 2 years and then up to 10 years time. 1,000 patients followed for minimum of 2 years, and then later on the last study that we did was 3,000 patients which have been followed for 10 years here. You'll see that when we look at the earlier results, that the patients with the two-feature negative plaque, there was hardly any likelihood of having an event. And essentially, that gave us almost the stability if these were the two-feature negative plaques, while there was 45 times higher likelihood of having an event over the next 2 years if these were the two-feature positive plaques. Not only that, the larger the plaque, and the earlier was the event, the larger the plaque, more likely was the event, as you can see here. And at that time, it really gave us a false sense of satisfaction that we will be able to identify all such patients. However, when we went ahead and looked at the 10-year studies, you will see that the high-risk plaques, which are pretty benign up to 2 years' time, up to about 2% of them, they would become they would also result in an event. Although the high-risk plaques, there still was 10-fold higher likelihood of having an event at that point in time. But the high-risk plaques, non-high-risk plaques, were really not as benign as we had thought earlier. Which were the plaques which result in an event? And these are the plaques which actually show a plaque progression over a period of time. So we had about 500 of these patients where we had 2 scans done at the baseline and at 1 year, and those plaques which demonstrated a positive plaque progression over the next year were the only ones which resulted in an event. And as you can see here, that although there was 10-fold higher likelihood of having an event when there was a high-risk plaque to start with, as I said, these plaques were not as benign as we had earlier thought. But at a given time, whenever you do a CT angiogram, 90% of the plaques are non-high-risk plaques, and only about 10% of the plaques are high-risk plaques. So at the end of 10 years, 50% of the events occur because of the non-high-risk plaques, and 50% of the events occur because of the high-risk plaques, bringing us to square one here. what exactly should we be doing? And now we have started to do these Shapley analyses where you are able to look at each plaque and each characteristic of the plaque and then give them the weighted score and try to identify as to which score will predict the likelihood of having an event, allowing us to even create the curves here where we will be able to define the likelihood of having an event over a period of time, and we should be able to identify as to what would be the time when the plaque would result in an event as compared to the other plaque which will follow a benign course over a period of time. So, if that becomes a possibility, would there be a possibility that we will be able to look at the time to stabilization versus time to event? And if the time to event is shorter than what a time to stabilization should be, then obviously we would need to intervene in these cases, while those which are likely to stabilize earlier than likelihood of having an event, we should be able to treat them by optimal medical therapy. Excuse me. Now, as you can see here, that earlier in 2004, 2005, when we had started to do these CT angiograms, we were able to identify the areas with the necrotic core. And when we started these patients on the statins, you will see that there is a resolution of the necrotic core in 6 months later. If the statins were not started, or if they were started and patients are not compliant with it, you will see that there was a progression of these plaques which could result in an event. We've gone further and looked at the intravascular imaging also. Here you will look at the intravascular ultrasound. Here you will look at the intracoronary infrared imaging, spectroscopic imaging. And as you can see that when the patients were put on the maximum statins, within 6 weeks time, there was a significant increase in the fibrous cap thickness, making them stable plaques over a period of time. Now, not only that you will be reducing the LDL significantly with the maximum statins, if we go further and if we add the PCSK9 inhibitors on top of these maximum statins, you will see that we will be able to reduce the amount of lipid core even further, as well as we will be able to increase this fibrous cap thickness, again making these plaques significantly stable plaques. And as you can see here, that within about 3 months' time, we were able to make 60% of the plaques significantly stable, and there was a reduction of the lipid core of approximately 33%. Not only that, if we do their transcriptomic analyses, we should be able to identify those people who are likely to respond to the statins and who are likely not be able to respond to statins, and whether they should be added on with the PCSK9 inhibition. Then which are the ones which will respond to the added PCSK9 inhibition and which will not, can also be deciphered. And these are the earlier studies which we are conducting at this point in time. Now, this regression became the actual possibility, as we remember from the 1990 study of Dean Ornish. It was a unique study. They had done the intracoronary angiography, and the invasive coronary angiography at that point in time made these patients to consume only vegetarian diet. They made them to do yoga, meditation, and the modest aerobic exercises. And it was Swami Sachidanand who had his yogic center in Denver, who had this influence on Dean Ornish at that point in time. For 1 year follow-up, they demonstrated that there was approximately 50 milligram% reduction from 145 to 95 milligram% of LDL over the next 1 year by change in diet and the lifestyle changes, the stress management and the vegetarian diet and the exercise. On the other hand, there was an increase in the LDL in those who were left as control, and there was an increase in their luminal reduction, while the people who were on the modified lifestyle and modified dietary pattern, they demonstrated a decrease in the luminal stenosis, approximately 5% reduction in the luminal stenosis. Now, this is the first time when there was a definitive evidence from the randomized study, and it became a possibility that we can identify such cases. You will see that if you really have to extrapolate the line whenever all the luminal angiograms have been done, if you want to come to a level where you want to demonstrate that there will be no change in the lumen, you will have to bring your LDL levels down to about 70. On the other hand, when we do the intravascular ultrasound studies, you have to bring them down to 70 so as not to show any increase in the plaque progression. On the other hand, if you really want to go for plaque regression, you will need to bring it further down under 70 to demonstrate a reduction in the plaque progression. If you look at the clinical studies and you put them all together, here are the primary prevention studies of the statins, and here are the secondary prevention studies of the statins. And if you put them all, these are all intravascular ultrasound clinical studies. And if you really want to extrapolate this line backwards to demonstrate that we would like to have the zero MACE, you will have to bring this down to approximately 50 or 55 milligram percent, something which the College of Endocrinologists back had demonstrated that 55 should be our goal, something which we cardiologists have been rather chickens to not being able to do that. European Society of Cardiology is the first to at least suggest that in very high risk patients, it should be brought down to 40 milligram percent. Now, if you go for a secondary prevention of the cardiovascular events here and extrapolate this line backwards to zero, you will have to bring your LDL levels down to 30. Question is, can we do it for the population? And this was a brilliant editorial opinion piece from Dr. Braunwald in the European Heart Journal in approximately 2 years ago, where he suggested that we should be able to bring the cholesterol level down of the entire community. He demonstrated that we need to reach a level of or a threshold of the atherosclerotic cardiovascular disease where we would have an event which normally occurs at approximately 70 years of age. You live better, it will become the life will be prolonged, and if you have the significant hypercholesterolemia, say homozygous here, this would happen by about 35 years of age. He suggested that if we start to give the inclisiran, which is the small inhibitor of the mRNA for the PCSK9, and just give one shot a year, we probably will be able to bend this line further, and we will be able to live up to 100 without having a cardiovascular event. Now, does that really happen in the real life? So we basically have been doing some very kind of intriguing studies. We have been going around the world. We have been looking at the mummies. We looked at about 500 mummies from various parts of the world, and we did not find any place where we did not find the coronary artery or the vascular calcifications. At that time, we were told that there is a tribe in Bolivia which lives around the river Manuki in the central Amazonian region, which lives very long. It is not a blue zone because there is no genetic advantage to them, because their genealogic cousins which live outside those tribal areas, they are as big as the other people living in Bolivia. They have got similar levels of cholesterol and all. So we started going there, and we started to do some of the CT scans in them. We did about 750 CT scans in them, and we have done about 3,500 carotid ultrasound in that particular population. As you can see here in Bolivia, and this is the river Manuki where these tribes are concentrated around there. These are the people who live in open huts. These are the people who eat jaguars, monkeys, or pigs, but eat only once a day. Or they fish piranhas, which they eat. Very few wild plants available to them, like papaya and some plantains, not the bananas, the plantains, which was the talk during the day when Dr. Mohan was speaking this afternoon. As you will see here, that they prepare stew and they only have it once at the night time. Whole day they are walking around trying to hunt for the food, and they walk between 15 to 20,000 steps a day. Here is one of my favorite couples at that time. This lady is 99 years old. Her husband is 85 years old. They were there to get the cataract surgeries, but they had 0 calcium scores in both of them. So you can see I'm examining them up there. So when you put it across the CT scans or their coronary artery calcium scores against the MESA populations and all the populations of the world, you will see that even at the age of 80, they hardly have any evidence of coronary artery calcium, be it men or be it women. Their LDLs are always less than 70. They're actually between 30 and 70. Their blood pressure less than 115, sugar less than 80, BMI less than 24, 15 to 20,000 steps a day, and no pollution. If they can do it, why can we not do it? And as you would see here, that there were 2 full-page, back-to-back coverages in the New York Times, Heart Healthy in Amazon, and Learning from Our Parents' Heart Health Mistakes. Not only those people, even if you look at our times now and the people living in the United States of America, here is the ERIC study. You'll see that the people who in their midlife, their average risk factor profiles, if were favorable, if you look at them 3 decades later, you'll find that they do very well and their coronary artery calcium scores remain 0. Here you would see that smoked, not smoked, and blacks, whites, female, males. You look at the blood pressure, various levels of blood pressure, and if you find the right kind of a risk factor profile, you'll see that there is no likelihood of having a coronary artery calcium score. Not only that, this issue, which just appeared yesterday of the European Heart Journal, where they have now looked at the cardiac study, where also they have looked at the atherosclerotic cardiovascular disease, even at the age of 18 to 40. And they have looked at it, the events after the 40 years of age, that if there was 1 standard deviation higher value of the lipid particles, there was 1.5 times higher likelihood of having an event, even in that young age. Look at all the animals of the world. They are smarter than us. Their total cholesterol levels are less than 100. There is only one animal in this world which is proud of 200 cholesterol, and that is human. Not only that, look at their electrophoretic patterns. All the animals have their HDL levels which are greater than LDL levels except human. Their HDLs are same as us, 45, but their LDLs are 20 to 25, and it is only human which increases its LDL. Do we really come with the very high LDL when we are born? No. What are our levels? Look at the study again from Salim Yusuf, as well as the study from the military hospital in Delhi, Kent. You will clearly see that we are born with 20 to 25 milligram% of LDL. And within 1 to 3 years of age, it becomes 130 to 150. What do we do to ourselves? And we proposed that it is all sugar. And we tried to demonstrate, and we hypothesized with Joe Hill and Tom Lucier, that the increase in the hyperinsulinemia through the mTOR, PI3 kinase, and AKT pathways produces PCSK9, which goes out, binds to the LDL receptors, denudes the hepatocytes of the LDL receptors, and that is the reason that we start to see an increase in the LDL levels. But the question only is, can I really do some kind of a study to demonstrate that there is indeed a long-term impact of the change in the sugar in the children? And that is something which was actually challenged. I was challenged by my daughter when she was pregnant, and that is what she wanted. What do I need to feed your grandchild with? And that is the reason that I have been now getting more and more excited about it. And here it comes with my close friend Tadeha Grackner from the Rand Corporation, that she published in Science recently, and it was the challenge. we need a random exposure to sugar-rich diet. You cannot do these randomized studies in children. So we needed to find a random exposure to sugar-rich diet early in the life with outcomes measured decades later. And she banked on the UK Biobank. 1953, after the World War II, the sugar rationing ended in United Kingdom. On 23rd September 1953, and she looked at the children born 1,000 days before and 1,000 days after. And what did she show? That there was a doubled uptake of sugar as soon as the sugar rationing ended. And this is the experiment on 23,000 kids. You'll see that the only change in the composition of the food is the sugar, while the fats, produce, and the proteins, they remain the same. And here you will see that the total calorie increase all comes from the sugar as at 1953 September. What is the impact? Look at the impact on type 2 diabetes. When you look at the in utero versus none exposure to sugar, there's about 12% risk reduction, 1.5-year delay in the onset of diabetes. And if you look at the in utero and 1 year plus versus none, no use of sugar, you'll see 35% risk reduction and 4.2 years delay in the onset. And then, if you look at the hypertension, something similar that we are able to see that there is about 20% risk reduction and 2.1 year delay in onset if there was no exposure to sugar as compared to those who have had 1 year of exposure and in utero exposure. So now we are working on the cholesterol. Here you will see that there is a sudden jump of cholesterol at 1953, about 40 milligram % increase in the people who are, in the children who are born after the sugar rationing ended in United Kingdom. Not only that, the level of the HSCRP or the inflammation is also significantly greater. And what you'll find amusing is that the rationed adults were more likely to attend any college and end up in a highly skilled profession and accumulate more wealth across their lifespan. So I would like to end with 3 points here, which I would say, one, which is the question which is often asked from you: what will happen if my cholesterol levels become too low? You remember this Ebbinghaus study. In the Ebbinghaus study, where the LDL levels reduced to 25 or even 15 in these particular cases, essentially there was no difference in the primary endpoints or secondary endpoints, whether it is the executive function, working memory, episodic memory, psychomotor speed, or whatever else it is, or the CANTAB scores or whatever. So there was essentially no difference, which was when the LDL levels decreased. So I would like to assure you here that there is no LDL cholesterol in brain. All the cholesterol in the brain is HDL. It is all produced in the glial cells and in the postnatal life. And it is produced in the neurons in the fetal life, but in the postnatal life, it is produced in the astrocytes. And this HDL, with the help of ApoE, is transferred over to the neurons. So do not worry about giving these statins. Do not just be a weakling. This pathway is very different than the pathway that bothers us. And why is it when people start to tell us that if you give these statins, you have less cancers, you have less pneumonia, you have less arthritis, you have less rheumatoid arthritis, everything is less. Is it really a nectar? Ye amrit hai kya? So we did a very refined experiment here where we did the X-ray spectroscopy, and we demonstrated that when you look at the lipid bilayers of any cells, the cholesterol, which packs the phospholipids, essentially when there is an increase in the cholesterol, and obviously when it is going from 25 to 100 or 130 or whatever else it is, this packing essentially compresses the phospholipids, compresses all your transporters, compresses your receptors, it modifies everything. Your natural killer cells may not be working, your calcium channels may not be working. So essentially, when you reduce the LDLs, your cells become better, you become more homeostatic. Obviously, everything will improve if your cholesterol level has reduced. I do not want to, because I know 0 there. So the last important thing, going to the community levels next year from World Heart Federation, we are likely to reach out to about 150 million people, where we will be going after the population approaches. And essentially, we are also doing something what we call as a city heartbeat index, where we are trying to level these metropolises based on their heart health, and we call it CHI, or City Heartbeat Index. We look at the social determinants, physical environment, health risk, health services, and governance. And based on that, there are 44 of the sub-determinants there, quite like you do the US News for World Report for the schools and colleges. We have now started to grade the cities across the world. And you'll be surprised if I tell you that the Hong Kong was the best city to live, followed by London and Madrid. We can talk about it later. So with my last slide, which is a reminder, what we define as normal, or what we defined as normal during the Framingham Heart Study, was not a normal value of LDL-C. It was based on the usual value for human beings which were at risk of dying prematurely from the vascular disease. Thank you.